Thank you again, everyone, for attending this newborn screening forum. This is the second forum for 2023, and this one is on our introduction of SMA screening, which is coming soon. To start the proceedings this evening, I would actually like to acknowledge the Aboriginal and Torres Strait Islander people as the traditional custodians on the lands on which we inhabit. And on behalf of all speakers and VCGS, pay our respects to elders past, present and emerging. And on a personal note, I'd like to give my support for reconciliation and the processes forward as we head towards the voice and other areas of improvement. Newborn screening in Victoria is funded by the Victorian State Government, and we work very closely with the Department of Health and associated bodies to bring in new conditions. The program has been running for over 50 years, but it's only in recent years that we've added new conditions. And for SMA, I'd like to, besides acknowledging the Victorian Government and Department of Health and Bharati and her team there, I'd also like to pay a special acknowledgement to Naza Marwab, who has been instrumental in doing the in-lab work and leading the work for SMA and also SCID introduction. And she's a stunning medical scientist, and we are very lucky to have her leading this project in lab. Tonight, we have three of us here. We have, firstly, Dr. Epi Yu, and Epi is the lead in the Paediatric Neurology Clinic at the Royal Children's Hospital. She's an honorary fellow at the Murdoch Children's Research Institute, and she leads neuromuscular and clinical research programs and has trained at the Royal Children's Hospital in Melbourne and also at the Sick Kids in Toronto in Canada. She has a PhD in neurological disorders, and her investigations encompasses clinical and translational research, including clinical drug trials for neuromuscular disorders. Epi this evening will be presenting on the clinical significance of SMA. Our other speaker is well known to all of you, and it's Mrs. Sally Morrissey. And Sally is our nurse educator. She is a trained midwife and has been coming around to educate many of you for well over a decade. Sally will be giving you an updated reporting process when we, so what will happen when we introduce SMA. Myself, I'm Rhonda Greaves, and I'm the Deputy Head of the Newborn Screening Laboratory, which is based at the Children's Hospital within the Victorian Clinical Genetics Services. And together over the next hour, we will give you an update and offer you a panel discussion towards the end. So please post your questions in the Q&A section of the Zoom. So our learning objectives for this evening are fourfold. The first two relate to Epi's talk, and we hope that at the end of this session you'll be able to talk to new mothers and babies about SMA screening, and also the importance of timely newborn screening collection and delivery to the laboratory. The next two objectives relate to Sally's presentation, and it talks about the changes for newborn screening reporting, and that you'll be able to understand these and the timelines for implementation of SMA screening, which I'll give you a hint now is looking like it's Q3 in 2023. But we'll announce that formally as we get closer to the date. A lot's been happening in the last few years with newborn screening. So newborn screening commenced in 1966 in Victoria with PKU. And in 2022, we introduced CAH screening, and we're looking at SCIDS and SMA screening in 2023, with SMA coming first, followed by SCID screening. This is really good news for Victorian babies. And the processes aren't really very changed from what we're used to with our other screening programs. We still have our standard birth collection and transport for our pre-analytical. We're aiming for an in-lab turnaround time to a referral of 3 days for SMA and SCIDS. And we're aiming for the post-analytical decisions, normal recollection or referral, by no later than 10 days of life for the baby. This is with the exception of CFTR, which is for cystic fibrosis, which has a longer turnaround time for reporting. SCIDS and SMA screening have been recommended for implementation as part of a more consistent approach by the federal government. And this is from the federal government website, and looking at the jurisdictions for implementing. And you can see on this slide here, Victoria's pilot for 2023 for both of these. Coming hot on the heels is announcements of whether X-linked ALD and sickle cell disease will be recommended for implementation. So these are due for completion, the assessments, in the coming months. And so we'll know whether they're also recommended or not to become part of newborn screening programs across Australia in the future. But tonight we're talking about SMA. And I'd like to just give you a little bit of an overview of some of the processes of implementing a new condition. From the point of funding, before funding actually happens, there needs to be a lot of planning to actually work out what funding is required and what might be required to do this implementation. So that's at the top here. Then we need to organise equipment and staffing and possibly reorganise our environment. Then we have the initial system suitability testing, and followed by a significant component of IT. We're dealing with 80,000 baby results every year, and the databases need to be really robust to ensure we're generating the right result on the right baby. So this system IT setup is exceptionally important. We also have the method validation and accreditation components, and background running and staff training. And it's the yellow dot and the red dots here is where we're at the moment with the SMA process of implementation. So this is my last presentation slide, and I'm very pleased to be able to hand over to Epi for her to begin her presentation on the clinical components. Thank you also again for attending.
Thank you, Rhonda, for the kind introduction. I'll just put my talk up here. There we are. Okay. So my name's Epi Yu. I'm a paediatric neurologist at the Royal Children's Hospital, and I'm one of the neuromuscular neurologists, and I'm leading the neuromuscular program, both clinical and research at the Children's Hospital and at the MCRI. So I'm really excited to actually be here today to talk about SMA, spinal muscular atrophy, in the context of newborn screening. This is something that we've been looking to implement in Victoria, and really excited that this is all coming to fruition. So let's first start by talking about what is SMA. Some of you may have heard what this is before. It's a genetic disorder affecting motor neurons in the nervous system. So SMA is essentially a type of motor neuron disease, and most people would have heard about motor neuron disease or MND in the media. This is a very specific genetic subtype, and it results in progressive muscle wasting and muscle weakness. And the problem in SMA from a genetic standpoint is that there's a deficiency in a protein called SMN, which actually stands for survival motor neuron protein. And just by the name, you can see that it's critical for motor neurons to function normally. And this type of SMA that we're talking about is the most common type of SMA, and there are actually other genetic types that are much rarer that we're not going to discuss. But it's due to mutations in a gene called SMN1. And this condition affects about 1 in 10,000 people. So as you just heard from Rhonda, we screen in the newborn screening lab 80,000 babies per year. So we'd expect to pick up on average about 8 babies who have SMA per year. And so what do we see in babies or people, children or adults that have SMA? Well, we talked about muscle weakness, so that's a very, very common symptom present in all people who have SMA at some point in time. We see something called hypotonia, which is low muscle tone, and in babies that manifests as floppiness and potentially abnormal head control. We see abnormal breathing patterns in some people with SMA, which is due to poor respiratory or lung function. And we also see swallowing or feeding problems, which, as you can imagine, may result in problems with weight gain and or aspiration into the chest with the food going down the wrong way. We also see the secondary effects of muscle weakness. So we see things such as scoliosis, which is a spinal curvature, which is often progressive. And we see things called contractures of the arms and legs, where you cannot actually extend your joint to the full range because of the muscle weakness. What's really important in SMA to remember is that cognitive function is normal in almost all people and babies, and sensation is normal. So parents often want to know if their children or babies can feel properly, and the answer is yes, they can. So this is a motor neuron, it's a muscle problem. And the thing about SMA that you're about to see on the next slide is that there is a very wide range of age of onset and also of severity. And this results in what we call different types of SMA, which I'll cover in the next slide. So you can see here that most people will think about SMA in 4 different types. You can see that it's actually a spectrum, but people have tried to categorize it into different subtypes just to get an idea of the age at which symptoms start and what the symptoms are for the person of that age. So the one that we really want to have a big impact on, not all of them, all of them, but essentially particularly so is SMA type 1. And these are infants who have symptoms before the age of 6 months, and usually by the time they're 2 or 3 months, symptoms are very evident. And unfortunately, this is the most severe type of SMA, and unfortunately, it's the most common type of SMA, affecting up to 60% of all people or individuals who have SMA in total. So these babies are very weak and they're very floppy, and they are never able to sit prior to the advent of the treatments that we now have. And I'll talk in more detail about that on the next slide. But if we think about the other types of SMA here, we have type 2, type 3, and type 4, and you can see there that the age of onset increases as you get to the higher SMA types. So for example, in SMA type 2, symptoms usually start sometime between the age of 6 months and 2 years, and children are able to sit on their own. They might need to be placed in that position, but they can actually maintain a sitting position, but they're not able to stand and they're not able to walk. And then when you think about SMA type 3, symptoms start after the age of 2, which means that these children can sit and they can stand and they can walk on their own, but they develop muscle weakness and that progresses throughout childhood. And then type 4 is the one that I don't tend to see as a pediatric neurologist. This is adult onset SMA. So children have normal motor development and normal muscle strength throughout their childhood, and symptoms start during adult life. And this is the most uncommon form. So unfortunately, the most common form is the most severe, affecting little babies. So I think this picture says it all. And we can talk about what we see in infants with SMA type 1. So we talked about severe weakness, severe muscle hypotonia or floppiness. So these babies, they have a marked head lag. Most of you will be used to checking babies when you pick them up. They usually have some head control, even soon after birth. These babies have very little head control. They have very little proximal movement or truncal movement. So that's the muscles close to the center of the body. And they have what's called a frog-legged posture. And they often cannot lift their legs off the bed. They might wiggle at their ankles or toes. They cannot lift their entire arm up off the bed if they're lying flat. And you can see this little baby shows what they classically can do sometimes, and that's just kind of bend up at the elbows and move at the fingers. But they can't actually lift their whole arm off the bed because they're too weak to do so. You can see this little baby, however, has no weakness of the face. She's got a very expressive face, and that's very classic of SMA. The other thing that you can see that's evident in this picture is that this baby requires a feeding tube. The baby has a nasogastric in because of the swallowing and feeding difficulties, which leads to failure to thrive and also problems with aspiration and chest infections. We see significant respiratory muscle weakness, and this leads to poor lung function. And you can see this little baby has a very, very narrow chest. We call it a bell-shaped chest. It's kind of flared at the bottom and it's very narrow at the top, which is kind of the wrong way. It's kind of inverse to what you would normally expect. And if we as paediatricians or neurologists or neonatologists check for the tendon reflexes with our tendon hammer, they will be absent. And we know that most babies will present within the first 6 months, but they're often symptomatic within the first few weeks of the first 2 to 3 months. And you may occasionally see a child that is actually already symptomatic in the first week of life. And untreated, these children used to die before the age of 2, and often before the age of 1. That's been our experience over the years. And this is really what's really changed, and why SMA newborn screening is so important, because we don't need to see this happen anymore. So just a little quick step through the genetics of SMA, because this is just important to understand, because this is what we're checking for in newborn screening. And we talked about this very special and important gene called SMN1. There's another gene called SMN2, which we're not going to cover, except just to clock that that actually exists. So in a healthy person, that person that doesn't have SMA, we all have 2 copies of SMN1 and 2 copies of SMN2. And we all have 2 copies of every gene in our body, one from our mum and one from our dad, and we have 2 there. If you have SMA, most of the time you're completely missing these yellow SMN1 genes. These blue ones are still there, but the problem is that this SMN1 gene is not working, and most of the time it's completely missing. And this is the case in about 95% of all people who have SMA, whether they be children, adults, or babies. What's just good to know is that in about 5% of people with SMA, there's a slight difference. So instead of both of the yellow genes being completely absent, there's still one there, but there's a spelling mistake in it. So one's missing and one has a mistake. And it's just important to realize that when we do the newborn screening, we only pick up these babies who have SMA due to the missing gene. And it means that there will be some babies that are missed, which is why we still have to be on the lookout for any babies who have symptoms of SMA. We can't just say, oh, they've had newborn screening. They can't have SMA. That may not necessarily be the case, and it's not a failure of the test. It's just a function of the types of genetics we see in SMA. So just something to remember. And this is a really important thing that's really exciting to talk about now when we talk about children and babies with SMA, in that there is now treatment for SMA. And we call these as a general group disease-modifying therapies. And what they all do is that they increase this missing SMN, or survival motor neuron protein, and that helps the motor neuron survive. And it's really dramatically changed the outcome for children with SMA, and now also adults with SMA, with amazing results on survival and motor function. And there are actually not just one, but there are 3 approved therapies, and they're all funded on the PBS. One is called nusinersen. This is the one that's been around the longest, in 2018. And then another one called risdiplam, and one called onasemnogene abeparvovec, which is always a bit of a tongue twister. And this is the type of gene therapy that people might have seen in the media in recent times. So these are all available for treatment of SMA. So babies with SMA type 1 now survive. And we have now young children who are 7 years of age attending school who were babies with SMA type 1, who were initially treated in the early clinical trials with nusinersen, and they are alive, they're going to school, and it's something that any of us who've been around for a while never ever thought that we would see. So, if you asked me 10 years ago even, would we imagine that this would happen? The answer would have been no. We would have always hoped for something like this to happen, but the fact that it's actually here is absolutely extraordinary. And we know that with all these treatments that there's this catchphrase that we use now, it's like time is motor neuron. And when people who talk about stroke, they talk about time is brain. For us, the motor neuron is the brain of the muscle nerves. So time is motor neuron. And we know that the earlier you start treatment, the better the outcomes are. And if you think about fewer symptoms, better outcomes. What about if you treat someone before they have any symptoms? Well, that's even better. And there's studies that have shown that if you treat children with SMA, what we call pre-symptomatically, so before there are any symptoms, the outcomes are even better. And we have seen children who were destined to have SMA type 1 to be like that baby in the picture have what look like pretty normal motor milestones, who get up and walk. And the initial infants that we have had have been siblings of children who have died with SMA previously, and we picked them up and treated them early. And it's extraordinary to see them get up, sit, walk, run around. It's not something that I ever thought that we would see. And along with this, we need to provide best practice multidisciplinary care involving all these people to look after these very precious young babies and children with SMA to make sure that they have everything looked after. So neurology, respiratory, nursing, physio, all the allied health, genetics, social work support, and dietetics and speech therapy. So we have all these people in our clinic to support children with these disease-modifying therapies. It's really important both go together. It's not one in isolation of the other. But why do we have newborn screening for SMA? It's because of this concept that time is motor neuron. So we want to see children diagnosed as early as possible as a baby and treating them ideally before any symptoms have developed, or if we haven't quite got there, as early on in their disease course as possible, because we want to see better survival, we see better motor outcomes, better respiratory and lung outcomes, better feeding outcomes. Some of these children who were treated early don't require nasogastric or supportive feeds. We see better quality of life. And if you look at the health economics of all this, again, even though these medicines are very, very expensive, the long-term lower health comorbidities and cost to healthcare are actually better overall in the long term. So just let's have a think about what happens when we get a positive newborn screening result, when this actually happens. So we'll get a call as the neuromuscular team at the Children's Hospital. It's not just me, it's one of a large team. I'll show you a photo of all of us at the end of this talk. But we'll get a notification from the newborn screening lab. And then us as the neuromuscular team will take over from that point, and we'll contact the family to arrange an urgent clinical review. Ideally, we're aiming within 1 to 2 business days. And at that appointment, we will talk to the family about what that results means. We'll examine the baby closely to see if there are any early signs of SMA, because sometimes there may be if we're looking for it carefully. And we will repeat the testing for SMA urgently to confirm the diagnosis in the diagnostic lab. And we're hoping to get a diagnostic result, hopefully, if we can get this all to work out, within 3 days of the sample arriving in the diagnostic SMA testing lab. And if this child or this baby is confirmed to have SMA, if they already have symptoms, then they are eligible for therapy. And we will talk about treatment options. There are obviously very complex conversations about what treatment is most appropriate, with a view to starting therapy as soon as possible. If these babies are what we call truly pre-symptomatic, then we can try and predict that type. Remember, we talked about types 1, 2, and 3, 4. We'll try and predict what type of SMA they have by looking at what's called the SMN2 copy number. And the access to treatment is quite complex. It depends on how many of those other little blue DAR genes are present. And some babies will be eligible, in which case we will commence treatment as soon as possible after counselling the families. Otherwise, we will follow these babies very, very closely, because as soon as they develop a sign of SMA, then we are able to treat them. So some of the complexities here, just to mention that there are some kind of finer print details here. The first thing I already mentioned is that not all babies with SMA will be picked up with the newborn screening test. It will probably be around 5%. We know from looking at Victorian data, it may be slightly higher in Victoria for reasons that we don't quite understand. But just to remember that not every single person with SMA will be picked up on newborn screening. The other thing to know is that not all babies who have a positive newborn screening test and who have SMA picked up as a baby will have infantile onset type 1 SMA. They may have type 2, type 3, or they may even have adult onset SMA, and we've picked it up as a baby. That's just kind of what's happening at the moment. And not all babies who are diagnosed with SMA in the newborn period will be eligible for immediate treatment, and they'll require close monitoring. But this kind of concept of close monitoring, early diagnosis and early treatment still stands, and newborn screening will allow us to achieve that goal. So just to finish up, I just thought I'd summarise just with a few points. So the first is that SMA is a type of motor neuron disease. The most common form is the most severe form. It's an infantile onset severe muscle wasting disorder without treatment. And the advent of treatment for SMA has dramatically changed the outcome for children and adults with this condition. We're aiming for early and or pre-symptomatic treatments of babies to provide the best outcomes long-term, and a successful SMA newborn screening program is critical for this. And always remember, for us from the neurologist here, time is motor neuron. So I'd be happy to take any questions at the end of this webinar. I just wanted to show, I said we are a multidisciplinary team. Here we are in the background. It's an older photo, but most of us are still around. And we are a range of neurologists, other physicians, and allied health, genetics and nursing. And we're supported by the hospital, the MDA, and Save Our Sons Foundation. So very happy to answer any questions at the end of the session. I'll just stop sharing here, and I'd like to introduce Sally Morrissey, who you all know is the newborn screening nurse educator. Thank you, Sally.
Thank you, Epi. That was amazing. I've learnt so much. I'm sure there's a few of us out there just worried that we won't have caught all that, but remember that it's been recorded, minus the pictures, and that will be up on the website. Mel will arrange that, so you can go back and review all that fabulous information a bit later on. I'm just mind blown. That was really great. Thank you so much. So I'm going to share mine now. Let's see how we go. This time, I hope everybody can hear me because I've got audio for once, unlike last time. So today, mine's just a very short presentation. I'd like to say hello to everybody out there who I haven't met. Welcome to tonight's forum. So tonight we're going to continue on with the theme of SMA, and Epi kind of not stolen my thunder, but she's just reinforced all those things that I'm always harping on about timeliness, and now we've got time is motor neuron, so I've got new taglines for everything. It's always a privilege to be speaking about newborn screening program, in particularly at this time with the massive expansion that has been projected for the next few years. However, even more exciting than that is thinking about all those families and the babies that will be able to help through early detection. I'd also like to reiterate what Rhonda has said and congratulate the newborn screening team for the implementation of this test. It's been an enormous task. We're nearly there, and hopefully it won't be too much longer before we can actually go live with that. So I hope tonight you'll find very informative, because I have already. Your feedback will be really appreciated. So if you have any questions, please put them in the chat and the panel will answer them at the end. So I'm going to be doing learning objective number 3, as in we'll be updating regarding the reporting process of the screening program. So tonight I'll be...
May I interrupt?
Yes.
Swap over. You're in the presenter mode. Swap over to the main slides.
Oh, okay. Sorry. That was for me to get everybody. I'll just stop script for a minute then. Sorry. It was just to make it a bit easier for me.
Apologies for
no. Is there? No. Let me just. Okay. Let me just do this. Sorry. I knew something would go wrong. There we go. How are we going there? All right. So my discussion points for tonight will be reminding of the tests and conditions. We'll go through pre-analytical, and of course I'll be harping on again about timeliness and quality. We'll look at some old photos of how the laboratory's grown. We'll go through post-analytical reporting, the referral process, and of course the provision of education by myself and Joanne. So let's remind ourselves of what tests we are currently performing. Last time we spoke was last year about this when we added CAH to the program. So now we've got 5 tests and we will be performing 27 conditions with the addition of spinal muscular atrophy by looking at SMM1. So just to reiterate, we do TSH for thyroid stimulating hormone for congenital hypothyroidism. We do the mass spec for the 23 metabolic conditions, where we look at 32 chemicals that give us those conditions. We do immunoreactive trypsinogen, which is the marker for cystic fibrosis, and those babies that have the cutoff go on for further mutation testing for cystic fibrosis, where we do the DNA mutation testing. As we discussed last year, we've got 17-OHP, which is the marker for congenital adrenal hyperplasia. And if this also meets the marker of 20, a repeat sample will be tested against a 5-panel steroid. And now we've got SMN1 for spinal muscular atrophy, which we look for the presence of the SMN1 gene. Reminder that both CF and CAH use second-tier testing for diagnosis, therefore they are required extra punching for testing, which means we need to be looking at the quality of our samples. So timeliness of the samples and quality is really important, and I suppose it's the most important component that I'm responsible for to ensure that my messages get across. So the reliability of the test is dependent not only on the correct typing, but also sample quality and ensuring that we've got sufficient blood collected for testing. And in saying so, we've got to 27 conditions. We'll add SCID, so severe combined immune deficiency. Hopefully later this year, we've got many conditions to go on, approximately, but we'll be up to about 35 by the end of 25. So we need to be starting to really think about how we can improve what we do. So after we've obtained a written consent from the parents or a guardian, it's really important that we think about the timeliness and the quality that will avoid the recollections and therefore delays in possible diagnoses. In March 23, we changed the collection timeframe from 48 hours to 72 hours to 36 to 72 hours. If you'd like to know more about that and you didn't see our presentation in March this year, I would advise you to go to the website and you can review all that and have understanding about where we came from in regards to that. Then what's important is the quality of the sample. Now, the conditions that we've been reading about that can affect SMA and also the other conditions that we are testing for is ensuring that the specimens are not ununiformly saturated with blood, that we do a good quality collection and we dry it correctly, that samples can deteriorate through exposure to heat and humidity. So for those out in the community that are going out taking sample collections during winter and summer, it's really important that you follow the guidelines that we have on the website so that those issues don't affect the cards, and contamination of the blood filter spot paper can cause abnormal results. So ensuring that we're wearing gloved hands when we're handling the cards, that we're using hand towel on benches that could be contaminated with all sorts of chemicals, with iodine, with MEC. It's just a matter of that's to try and keep everything that we do clean for that sample. It's important then that once we've taken that really good quality sample, that we dry it horizontally for 4 hours. We send it in paper, not plastic, and we must send within 24 hours via a courier or express post. We are having increasing problems with express post. Those that are still using express post will be finding that their KPIs that they are sent from the Department of Health will not be reaching the target set at 95%. We are constantly working on this, but it's something that we always need to be mindful of, particularly when we've got a clinician just telling us now that we really would like to start treatment for these babies by day 10 of life. So the next exciting thing is to look at how we've actually grown in the period of time of just the last 12 months. For those of you who have seen the website in the past, this is an old video. Well, it looks quite old now, a very one done by the Department of Health. And these stills are just some shots to show you what the lab looked like back then. But what you will see now is that we have expanded exponentially. So with the addition of SMA and SCID, we've had to implement new equipment, and it's not small. That space that you saw before is now basically taken up with one massive piece of equipment, and that's the DNA extraction by Biomech. This is Chris modelling for us here, and this is where the DNA extraction takes place. This is inside the biomech. You can see the plates, everything's contained within. And then once all that prep and everything has been done, it goes into this quant studio, which amplifies the DNA, which enables us to be able to look at which babies are showing that they have the SM1 gene or they don't. So the post-analytical reporting is basically what happens after the initial testing is completed, so that the batch has been finalised, it's been analysed, and it's the stage where we determine whether the sample needs to be retested and when do we refer. So what do the newborn screening team expect for a normal response for SMN1? This picture depicts internal controls, or as NASA has been prepping me on this, housekeeping gene RPP30, which is in the blue. You can see that quite clearly in the blue, and you've got the other genes being SMN1, they're being in the green. This indicates how many cycles, sorry, go to the horizontal line. You can see what is called cycles. This indicates how many cycles it takes for the presence of the SMN gene, M1 gene, to break the threshold, which is the lines that are in the center there of that picture. If you look closely at the green line, that is for SMN1 gene, it demonstrates how, if the SMN1 gene is present, the normal amplification response that should occur, which is roughly between 15 and 13 cycle thresholds. So you can see here between 15 and 30, that's what you would be expecting for a normal response for a baby that has the SMN1 gene. So an SMN1 referral for SMA, if we have a look now, so now if we look closely at the actual baby sample, so this is actually from a baby that has SMA, we can see a blue line representing SMN1. So there we have the blue line here, okay? We can see how this baby's cycle response does not cross the threshold. So there's our threshold here. It does not respond like we had in the previous slide. I'll go back to the previous slide. You can see that there next to the housekeeping gene. We can see the housekeeping gene here and the baby is not responding, indicating that the SMN1 gene is missing and that the baby needs to be referred for SMA. Thank you, NASA. So next, what we have to do is we have to do our normal reporting. And so the normal results will show the amplification of SMN1 between 15 and 31.24 cycle threshold. Now, this will be released on the weekly report, which is sent out Monday electronically to all the newborn screening liaisons as per normal. The changes will be the addition of the SMN on the bottom here of the report, weekly report, which now indicates the 5 tests, 1, 2, 3, 4, 5 tests that we now perform on site, which is amazing. The referral paperwork, if we have a baby that has an abnormal SMN1 amplification, will be sent after contacting Epi and her team. As you can see, we've got the normal referral paperwork. It'll have the tests that we've performed, the result with the reference range. On the back of that paper, we have that a baby is at risk of spinal muscular atrophy. We'll ask for some details so that we know what's going on. We'll also ask for the SMN copy number and the SMN2 copy number, which Epi described as what needs to be tested to determine the severity of the condition that we're actually looking at. And we've asking for some extra information. So symptomatic, pre-symptomatic, or no SMA after they've been seen by the clinicians. So as I said before, the samples without amplification with no cycle threshold will be retested, and once that's confirmed, we will be referring. The team will be contacted, as Epi said. An appointment will be arranged, as she said, in the next 1 to 2 business days, and they will retest the baby's blood and send off for confirmation of all the 2 genes that we were just discussing. Education is a really important cornerstone to this program. It's really important that we remember that the information that we obtain by attending these sessions allows us to be able to better inform parents confidently about what we're doing when we're performing the newborn screening test. Joanne and I are available at a time that suits you, that is when we're available and you're available. We cover all platforms. We now have had the great pleasure of going back to face-to-face, and it's been really exciting to be able to talk to everybody and get the feeling about how things are going, because it hasn't been going very well. It's nice to be able to see people, to answer their questions and answer their concerns. So face-to-face is available, as well as the online platforms as well. You can go to the VCGS resources page and you can add in those request details there, and Joanne and myself will get back to you, or you're more than welcome, can just drop us an email to newborn screening, or you can always just give us a phone call. We're available Monday, Tuesdays and alternative Wednesdays. I'd like to also thank Naza Madwad, the medical scientist responsible for implementing this new test. She's amazing, and she's been an amazing help for me over the last few weeks as I've been trying to get my head around another new condition. I hope I've done it some justice tonight, and as always, I've always got Rhonda to help with assistance with reviewing that I am on the right track and that things are going okay with my presentations. So thank you for everybody for listening. Now, what we'll do now is we will head to the Q&A. So if you'd like to put your questions into the chat box, we will all be up online to be able to speak to you.
Beautiful, Sally, beautiful presentation. Here comes Epi. Wonderful presentation, Epi. I've learned so much also. Whilst we're waiting for some questions to come into the Q&A, which is online, I have a couple that have been sent to me directly over the time. So one of the questions that I had was really about the sample collection, and it's for you, Sally, I think in particular. And with the sample collection, how does the SMA, the addition of SMA, affect the sample collection?
Thanks, Rhonda. That's a good question, because, you know, it's a bit daunting thinking that we're adding on all these conditions or tests, which will, you know, like one test will do both the SMA and SCID. So that's good. So at the moment, that's good. But we've got galactosemia, we've got hemiopathies to arrive. So there's going to be a lot, and like I said, about 35 conditions in the next few years. So what I would say is currently we will be probably staying with exactly what we have, the 4 dots at the moment. But I need to really emphasize the importance of the quality of the samples that we are collecting. Now, Joanne's been working feverishly in the background on a video. It's not that easy to try and capture a baby on site at the Women's Hospital in the time frame that you can get in there when the sample with a camera crew and everything else. So she's been beavering away at that in the background, trying to get a really good up-to-date quality video on sample collection. So in the anticipation of that, we will release that new video going forward with probably one of the next forums. And I think it's really important that we all go back and we review what we do. Going back to basics, I think, is really important. Remembering that the baby needs to be prepped, that we need to have all our ducks in the row, all the card filled out completely, that we need to minimise every effect that we can of contaminating the card, and that we need to then ensure that we do a really good quality sample with what we have, with the 4 dots that we have currently. If we have to add more, you'll be certainly notified early enough, but if we can maximise what we have now, we can add conditions, but we more than likely will have to increase the number of dots over time. Do you agree, Rhonda?
Yeah. We don't want to make it harder for everyone. So at the moment, it looks as though we have enough with our 4 spots. We have to see where things move over the next few years. We are also going to have some, some changes with genomic, potentially newborn screening coming into the mix. I beg your pardon, over the next decade. I'm so sorry. Apologies, everyone, for that little hiccup of mine there. There's a question here which is definitely an EPI question. Epi, what would be the eligibility criteria for immediate SMA treatment?
Yeah, so that's actually a really good question. I did say that it's a little bit complicated. So the first way to think of it is this child symptomatic or not? So are there clinical symptoms that we could attribute to SMA, or on neurologic examination, does the baby have muscle weakness? Does the baby have absent tendon reflexes? We can get out the little tendon hammer. Does the baby have swallow difficulties? Does the baby have excess head lag? So once you've established that if that child actually does have some early symptoms, that is enough to basically make that child immediately eligible for any therapy. So that's kind of one group, and that's kind of ideally we want to see them pre-symptomatically, but we know that those children can access all of those therapies that I mentioned. And it's a very big discussion about which treatment option to choose, and it can be quite complex. The other one that we're faced with, which is actually what we would like to see, we want to find these babies pre-symptomatically or before they have any symptoms. And in that case, we remember we all talked about the SMN2. So the SMN1 is the gene that is faulty or completely missing 95% of the time. So we'll pick up that 95% of babies with SMA who are pre-symptomatic because they're missing those 2 copies of the SMN1 gene. You might remember in that slide I showed that the SMN1 genes I had as 2 little yellow markers, and then there was an SMN2 gene which was in blue. And that actually determines the eligibility. And what we understand about SMN2 is that the more SMN2 you have, the milder your type of SMA is. And the reason because of that, and I didn't have time to go into this, is that SMN1/2 is almost like SMN1, but not quite. So it's a bit of an NQR version. So it actually does make some of that very important survival motor neuron protein. And so the more copies you have of that, so some people might have 3 or 4, and they usually have the later onset types of SMA. Whereas babies who have SMA type 1 generally only have 2 copies or sometimes even only 1 copy, which is why they present with their symptoms earlier. And basically at the moment, and this is a changing landscape, and because even like a year or 2 ago, there was no treatment for pre-symptomatic SMA outside of a clinical trial. But essentially at the moment, the PBS criteria state that they are only eligible if they have 2 copies of SMN2. So if the baby has 3 copies of SMN2 and truly don't have any symptoms, and we're going to look very hard for any signs of symptoms, including doing something called a nerve conduction test to pick up something early. If they really don't have any symptoms, all we can do at the moment is monitor them very closely. So we would probably see them every 4 to 6 weeks for the first 6 months to try and pick up any early signs to see if they're having symptoms in the first few months. And as soon as we can pinpoint something, then they can be eligible for therapy. I mean, to me and to most of you who are listening to this, it probably doesn't make a lot of sense that why are you waiting for these babies to have symptoms? Why are you waiting till they're 9 months of age and they've had some problems with the motor neurons already and they manifest symptoms? And there's been a lot of lobbying to the government and the PBS to try and expand the eligibility to at least include those with 3 copies, if not 4 copies of that SMN2. So at the moment, it's a little bit complex, but essentially the summary of all that is that anyone who has symptoms is eligible, any baby, and it's those with 2 SMN2 copy numbers, and those other babies who are not yet eligible are watched very closely like a hawk so that we can try and pick them up and put them into the very early symptomatic stage and treat them then.
Thank you, Epi. I've got one that's come through for Sally. And Sally, I hope this is, I think I'm directing it correctly here. Sally, this is probably for you and Joanne. It's from a midwife asking what would be the key messages that you would ask them to give to parents to explain SMA screening? Oh,
good question. Right, I haven't thought about that one, but let me think about that. It's difficult because depending on what your where you are, is it in the antenatal clinic and your time constraints, or is it at the bedside when you're giving the brochure? I think the most important thing to talk about with the whole of newborn screening is that we're identifying babies at risk of very, very rare conditions that can cause death and disability. And the ideal of newborn screening, its timing of it, is to ensure that we identify those babies so that we can commence treatment early. Now, the introduction of SMA just probably highlights it even more, even though the other conditions are just as important, but I think this is more obvious and has been in the media a lot more, particularly over the last few years, and has received a lot of publicity. So parents may actually know about it when you go to talk to them about it. But I think the key messages are that the timing is always important, that the conditions that we're treating are rare, that if your baby is found to have a screening result, that it will be referred immediately to a treating team, whether it be for endocrinology or for cystic fibrosis, for respiratory, or to Epi's team here at the Royal Children's Hospital, where they will be, the neuromuscular team will be the only one in the state currently that will be looking after these babies, that the families will be contacted and a plan start immediately. So parents can be reassured that the testing that is done, if they don't hear anything, it will more than likely, it may take up to about 3 weeks, 2 to 3 weeks, if we're going to have the final result for, as Rhonda said, for cystic fibrosis, because it goes off for that mutation testing. So for a normal result, it can take 48 hours, just say, to turn around, but those normal reports get sent back to the hospitals, and parents will not hear anything about it. But for those families that are affected and picked up by the program, they're going to be notified very, very quickly that there's an issue and a treatment option put into place. I think that's it's very tricky when you're not in front of a patient. I think you just need to work out what's best way of doing it for you, but that's how I would approach it.
Thank you, Sally. I've got one more question that's come through here, and I'll just read it. I think it might be more of an Epi question again, but maybe not. It might be. It's about the testing, and for preterm versus full-term babies. Is there anything that we need to be worried about in terms of preterm for an accurate result?
So that's actually a really good question. It's something we've been trying to pre-plan for. So my understanding, and Rhonda and Sally can correct me if I'm wrong, is that, I mean, it's a genetic test. So unless there are issues with the sample, because of prematurity, I know there are some considerations there. As a genetic test, your genetics doesn't change. So from a genetic test perspective, any time you did a genetic test for SMA, if you have SMA, you should pick it up, assuming the DNA quality is there, etc. The next question that's really important that we are trying to work out what to do is that if you have a preem, just say it's a 30-weeker, and they're picked up with SMA, what do you do? So at the moment, all the studies have been in babies who are at least kind of 36 weeks gestation, and there isn't a huge precedence for what is done for very premature babies. And we know for things, for example, like gene therapy, that people have potentially given it, just as term is reached at 36 weeks or 35 to 36 weeks if you're going to push it, and same with the other therapies. And there's just some subtle variations about what you can use at what weight and what age. But for all intents and purposes, we would find a way to treat them safely as soon as we could from a disease-modifying therapy standpoint. The other thing that's quite important to say is that sometimes we do see very, very severe, almost like what we call type 0 SMA, where the babies are very symptomatic and very weak already in utero, and are symptomatic in the neonatal period, and maybe, for example, ventilator dependent. And with that degree of severity, and actually even a baby with SMA type 1 who is symptomatic, we always say there are not 3, but there are 4 treatment options. The 3 treatment options are the 3 medications that I talked about. And the 4th option is actually not to treat the infant. And sometimes that still happens when we see some very severely symptomatic neonates in the ICU or NICU. And not treating is still sometimes a consideration depending on the severity and what works for that family. Because the child, as you saw, who is already symptomatic, significantly so, these drugs are not cures. They certainly change the outcome, but they still have muscle weakness. Some of them still have breathing difficulties that need support. So just something to keep in mind. It's a complexity that we deal with when the patients get to our end. But if you've got a symptomatic, very premature infant, that's very different to a pre-symptomatic premature infant.
Thank you, Epi. And Sally, thank you also. May I just add just a fraction to the preterm? Heparin and heparin lines can potentially interfere with PCR assays, and this is a PCR assay. So we do need to be mindful of that. We think we'd probably catch it in the lab, but any contamination, if it meant a recollection, that's obviously a delay in referral if it happened to be a baby. So the quality of the collection, as Sally said, is really important. And I think that sits with the special care nurseries in particular. We're right on 1 minute to 8:30 in Melbourne time. And so I'd like to ask everyone to fill in a survey to see what they thought of this presentation, and so to provide the feedback. And I'd like to take the time to acknowledge Epi's time here this evening to come in and give this presentation, Sally's time to come in and give this presentation in the evening, and all the maternity service providers who do a fantastic job at actually getting the newborn screening samples collected and into the lab in a timely manner, and are making our lives so much easier. And of course, I can't go without acknowledging all of the terrific team at Team Newborn Screening and Team VCGS. So thanks everyone for listening. Oops, I forgot someone very important, Mel, who's hiding in the background here. I beg your pardon. Mel has been working in the background, setting up all of this video and the Zoom links. So thank you, Mel. And on that note, it's 8:30 and we'll say goodbye.